Okay.
Did you hit record?
Yes,
Thank you.
I think so. Let me check again. Yes, it is recording.
Thank you.
Good afternoon. How are you guys doing? Ready to learn the science aspect of the electrolyte balance, imbalance? So today we are focusing on the fluids and electrolytes, right? So these are your learning objectives. Basically, I think there are two sections. So in this osmoregulation concept will be more detailed, discussed in the clinical aspect. I'll focus more on the hormonal regulation, how it's involved in the fluid and electrolyte movement. If you have any question on osmoregulation in the clinic, the science aspect, I think you can maybe reach out to me and then we can talk more. But let's first focus on, because these are really big units, so I wanted to focus our discussion on second, the hormonal regulation, and then the electrolyte balance and imbalance. So hormonal regulation. So let's look at what are the hormones involved in these electrolyte and fluid regulation. You have already heard about these hormones in your cardio in all different times. So it's just bringing it back here with respect to the electrolyte and the fluid movement specifically. So these are aldosterone, antidiuretic hormone. We'll talk the very little, like to some extent, the natriuretic peptide, and the parathyroid hormone will be discussed more in your calcium by Dr. Hall. So I'll leave that for that discussion, but briefly we'll mention about this parathyroid hormone. But basically we'll discuss the first three. So here, when we talk about aldosterone, how would that get affected, or what stimulates these hormones in the kidney specifically is when there is low blood sodium, or if there is increased potassium level, or there is a decreased blood pressure. So all these are stimuli for what then it will act on the kidney. And that will tell the kidney to release this aldosterone. Where is aldosterone released from? What structure? I heard adrenal cortex, right? Which is on top of, which sits on the kidney, right? So when the kidney senses this low sodium, increased potassium, or decreased blood pressure, it relays that information and releases the aldosterone. Okay. Once the aldosterone is released, it through this pump, sodium KATPase pump, it will cause a reabsorption of sodium and excretion of potassium. The whole goal here is to increase the blood osmolality because you have low sodium, right? If you have low sodium, the solute concentration is going to be low, right? So that will cause a decrease in osmolality. And also the volume will be low, right? So osmolarity and osmolality will both drop. So what you have to do is regain. So it is coming back to homeostasis through the aldosterone hormone, okay? So those are the stimuli for releasing the aldosterone and bringing that back to osmolality, back to the homeostasis. So now we talked about bringing the sodium because the stimuli is because low sodium, we release the aldosterone to bring the sodium back. So now we also need to worry about the volume, right? How would you bring the volume or increase the reabsorption of water is through another hormone, the antidiuretic hormone. We all have learned about this hormone as well. And it's also in the body, we call it vasopressin. So they both are the same, antidiuretic hormone and vasopressin. So how are they released? The same, when the stimuli here is blood volume has decreased, so the blood becomes concentrated due to dehydration. So then that's when this hormone is released. So they go hand in hand, aldosterone and antidiuretic hormone. So these, like there are osmoreceptor in your hypothalamus in the posterior pituitary, which will get stimulated, and that would increase the production of this antidiuretic hormone, then leads to insertion of water channel on the cell, and that leads to increase in the water absorption. That's simple, in a simplified form. So that helps in regaining the blood volume, which is maybe was low because of low sodium. Okay. So the next is, we also talked about natriuretic peptide. So there is an atrial natriuretic peptide. Atrial natriuretic peptide, by name, what do you think, where will it be produced? In the atria of the heart, right? So not only the kidney is involved, but here the heart is involved in regulating your blood volume. So whenever the stimuli here is, like right now in the previous two ones, we corrected for low sodium and low volume, right? But the opposite can happen when there is a high volume. How would you correct it back to homeostasis? So this is where this comes in. So increase in blood volume, the atria is going to stretch, and that will stimulate the release of ANP. So this ANP release is to decrease the blood volume and blood pressure so that it can bring it back to homeostasis. So it is kind of the opposite action of ADH and aldosterone. So these two regulations are important for maintaining the blood volume and also the sodium, the osmolality. Yes.
So when you say opposite actions of ADH, how does it do that?
Because the ADH is going to be causing an increase in volume, right?
So how does it specific do that?
Huh?
Then how does it do that? Does it is an antagonist? How does it do that to stop the action of ADH and just
It's not like directly opposing the action of ADH. It's like one signaling winning over the other signaling. So ADH is a hormone, right? So hormone level goes up. So you have increasing in the volume but now the increase in volume has gone maybe to a really high level. So now the ADH doesn't need to be secreted more. So there is a break because what you're feeding this blood is to the heart too, right? The heart is also sensing there is an increase in the volume of the blood. So now it needs to balance, bring it back down. It's not pathophysiology, it's a physiology. So the volume of blood that is received by the heart is now high. So now the heart starts releasing ANP to decrease the volume.
So when that is released, it basically stops the secretion of the ADH.
So it's like a physiological, like ADH level will go down because now the water needs to leave. So the water channel is not going to be inserted into the cell. So it's a trigger, like one triggers the other. And so like the balancing act of how much is released, it's not like all or none response. So there is always a ADH level in your body. There is always this ANP level in your body. Depends which one is going really high and which one. It's like a balance. So your osmoreceptor will not get stimulated to release ADH if you already have corrected the volume. If the water needs to be excreted, the osmoreceptor is not going to be stimulated. So if the osmoreceptor is not stimulated, you won't release ADH as much. There will be some release, but not as much. Does that make sense?
My question was, does the ANP, is that what is causing the osmoreceptor to be stimulated?
So ANP has nothing to do with the ADH stimulation or inhibition. They are two different mechanisms appearing in two different places. One is happening in the kidney, the other is happening in the heart. So they both are sensing their own way the volume of the blood. The kidney is sensing the volume at the blood at the nephron level. the heart is sensing the blood volume at the, like whatever is receiving. So they are completely two different mechanisms. And there is no crosstalk that way. So it's not like the ANP is acting on ADH. Yeah? I know it gets a little bit how to relate all this. It's more like when you're seeing that two different organs are being impacted with the blood volume. One is happening in the kidney and the other is happening in the heart. Because they are all interrelated, right? The amount of blood that the kidney is going to filter is what the heart is going to pump out. So the other hormone that I'll just briefly mention here, because since we are talking about hormonal regulation, is the parathyroid, which are parathyroid hormones secreted by the parathyroid gland, and this is sensed by the low blood calcium level. So how would the kidney will sense the low calcium, so it will reabsorb, whereas the parathyroid hormones, it increases the calcium absorption in the intestine and the bone, which you'll learn more in your calcium unit by Dr. Hall. So just wanted to mention here, calcium reabsorption also occurs in the kidney through the parathyroid hormone pathway. So moving on to section 2, now let's focus on how these electrolyte balances are being regulated and what factors affect them and how there are imbalances and the therapy part. So let's first we'll look at sodium and potassium. So we all know that this pump, right? The sodium potassium pump. It's an energy driven pump. So it requires ATP. So how many sodium you can see that is leaving the cell through this pump? 3. And how many potassium are coming in? 2. So it's 3 to 2 transport. And as you can see here, the ATP is involved in opening of this channel and closing of this channel. So the ATP is the driver for exchange of these two ions. Keep that in mind. So let's now take a look at sodium. So we know that these sodium and potassium, we talked about the sodium potassium pump that the aldosterone acts on, right? And then we talked about how this pump is involved in transporting of the sodium and potassium. So this sodium potassium is regulated by the aldosterone, and this will influence the sodium reabsorption, and this will influence also the potassium excretion. And that's how it's going to maintain the sodium and potassium level by this hormone. I think we already reviewed this. So let's see now what are the causes and effects, and if there are imbalances of sodium, what happens. Because this is, so far we're talking about the physiological level, how this pump is involved, okay? So there are two different cases of, there's a higher sodium or lower sodium. So higher means too much sodium is hypernatremia, too little sodium is hyponatremia. You'll learn the clinical in Dr. Gonzalez's lecture, but let's review what happens. If homeostasis is disturbed, right? In this case, hypernatremia, there is increase in sodium. So now it has to go back to homeostasis, means it needs to lower the sodium level. How does it do that? By diluting. So by diluting means it takes the help of antidiuretic hormone, right? So the antidiuretic hormone, how are they stimulated? First, you have to stimulate the osmoreceptor. That will release antidiuretic hormone that causes an insertion of the water channel. The water will come in through, like you'll be thirsty and you'll drink water and you'll have a more increase in water gain. and the volume will increase. When you have more volume within the same sodium, the sodium level will go down. So that's how you are going to correct the sodium and bring it back to homeostasis. This is, as we already mentioned here, how that happens. Okay. The opposite will happen if there is hyponatremia, means decreased sodium. Right now, you don't want to further dilute it, so you actually inhibit the osmoreceptor. So no more insertion of the water channel, so no more thirsty, so you build your sodium level increase. So that's how you decrease your volume and bring it back to homeostasis. This is still physiology, but let's see if we are not everyone is able to correct it, so that's where you need the therapy, right? So let's move on to the mechanism of how, if there is a drug available, how can it help correct? So for hypernatremia, you want to use these two drugs, which is the vasopressin agonist and also desmopressin, which is like these two drugs that are going to help you, because remember, maybe the ADH levels are not as good in some patients, so you have to artificially provide them so that they can stimulate the insertion of the water channel. Okay, so here we are hijacking our physiological approach. So here, using this drug, it's going to increase the water absorption. So this particular drug actually binds to a certain V2 receptors on the channel, and that's how it'll increase the channel in the membrane and increase the permeability. So this is how it will work. So this is the cell, and this is your desmopressin drug. It's an agonist, so it will bind to a V2 receptor on the cell, and through the adenyl cyclase, increase the pKa activity, which helps in the insertion of the water channel. So in very brief way, like this is a signaling pathway. The drug has to bind to a certain receptor to activate, to increase in the water channel insertion is through this pathway. So that's how it will increase the water permeability, decrease the excretion, and reduce the osmolality. Because what you are trying to achieve is, because it's a hypernatremic condition, you need to dilute it, right? So you need to reduce your osmolality. Okay? So the next is, I want to also mention here that these medicinal care, how these two molecules are similar or different. So vasopressin is what we all have. It's a physiological, but desmopressin is the drug, right? So we are trying to mimic the molecule. We're trying to mimic what we have. And so you can see here, there are some addition that we'll talk about why it is important. So let's take a look at vasopressin. So these, there are different structure within this molecule that will provide different activity, which is important. So for the agonist activity, this bridge is important. So if you remove this bridge, it's no more active. So that's an essential moiety within the molecule. So then there is another moiety here, which is that amine group. So if you want to increase the duration of action of vasopressin, you need to deaminate. So if you can see in the previous slide, so this is deaminated, right? There's no amine group here. So if you want to increase the duration of action of vasopressin, you remove this amine group, which is removed in the desmopressin. So that means it can act for long. It doesn't get destabilized. So then there is also selectivity. There are different receptors. V2 is what we are talking about, but there are V1 receptors. So if your drug wants to be more selective to V2 versus V1, then these are the modification you need to know, we need to do. So these things are studied more when the people are developing new drug molecules or how to make the drug better. They can do deamination so that if the V2 has more selectivity if there is deamination. And then there is also amino acid glutamate here. If it gets converted to, you can convert to valine, that will also increase the selectivity. And this molecule, this moiety here, L-arginine, if it's converted to D-arginine, then the drug is more selective for V2 than V1. That's something med chemistry, like I just want to point out to you all. So that not only these molecules do their job, but also how their properties can change based on if you make some of these changes. So moving on to hyponatremia. We talked about hypernatremia. Let's look at hyponatremia, how this is treated. So if hyper was treated with the agonist, what do you think a hypo would be treated with? Antagonist, right? Because you want to block the receptor. You want to build the osmolality, you have to raise the osmolality, so you don't want more water channel. So here, these are some of the molecules or the drugs that you will learn, but I just want to mention the mechanism of these. So first, let's take a look at the medicinal chemistry. So this particular group is not approved in the US for treatment, but I just wanted to mention here, like V1A selective antagonists have been produced, and they are more beneficial when there is resistance, the total peripheral resistance is increased in your vessel. So that's only when it was but no one has used that. So I don't think we should care about this group. So let's focus on the two other groups here. V2 selective antagonist.
The V1 is selective antagonist. Is it used anywhere in the world?
I don't know. That's a good question.
I'm not sure either.
Maybe, I don't know what are the examples of that. I haven't looked into that.
So I don't know of any.
Yeah, maybe we can see if there are any. So V2 selective antagonists, tolvaptan, and V1A, V2 means they are not selective antagonists. They are used in different times. So here, if it's beneficial when there is excessive reabsorption of water, and it's beneficial in a disease state, maybe when, I don't know which kind of disease state would that be, but maybe you'll get more information on that in your clinical. But basically, these two are the two different groups you'll be using. In here, one is more a V2 selective antagonist, the other one is not selective. It can act on both V1A and V2. So the mechanism is a blocker. So it blocks this V2 or V1 receptor. And so once it bound, then this signaling pathway is not going to happen. So PKA signaling pathway is going to be blocked. So there won't be any insertion. Actually, more of a degradation of the water channel happens. So they don't get, not only they don't get inserted, but whatever is there on the membrane gets degraded. So that's how you prevent the more water coming in. Okay. So every drug has some side effects. So I just want to mention by using this antagonist, actually you create an increase in the potassium level. So you have to be careful with how much you're treating these patients for correcting for hyponatremia, but in return you can build hyperkalemia, means increase in potassium level. Because think about that, sodium potassium channels are acting, right? So it's not like you can correct only one and not worry about the other. So for every 3 sodium leaving, potassium comes in, right? So that maybe you're building up your potassium because of this drug. So now let's move on to our potassium. So far we talked about sodium, right? So let's talk about potassium. So potassium, there are different things potassium is associated with, like osmosis. where intracellular fluid, where does potassium higher? Inside the cell, right? So where the intracellular fluid, if your potassium levels are going up, it will impact your osmosis, like the water movement. Osmosis is nothing but water movement, right? So that will be affected. So it also it plays a role in the acid-base balance, which we'll talk in a minute, and also it impacts your resting membrane potential, which is where in the kidney, huh? In the heart. But do kidney have resting membrane potential that we need to worry about?
All cells have resting membrane potential.
Huh?
Like all cells have a resting membrane potential.
All cells have, but does it matter for the kidney cells? Does it fire? Or does it change a lot? They are mostly in the minus negative, like negative. Majority of the cell, except for the neuron and the heart cells, they live in minus 80 to minus 90. Yeah. So even if it changes a little bit, does it matter? Maybe not. Where it matters is in the neurons and the cardiac cells, right? So that's where the resting membrane potential will be important. If potassium in your blood levels are varying, it's hyper or hypokalemia, then that would affect the firing of the action potential in your neurons or the cardiac, right? So, and also remember there is a threshold that the membrane lives in. So at minus 70, it's not going to fire. But as the membrane is becoming more positive and it reaches minus 55, like that's where the action potential upstroke will reach its maximum. And then the rest, you know what that is. So sometimes, like you can see that a small trigger can happen, which can be arrhythmogenic. So those are the stimulus could be related to potassium. Okay. So when there is more potassium, it's going to move, the threshold is going to move closer to the gap will close, right? Because potassium will make it more positive. So you have a higher chances of opening the sodium channel, but the sodium channel can close quickly because they close at certain threshold. So that's why it's not going to do a complete stimulation. So there's little blips of action potential that are arrhythmogenic. That is more of remember the phase 4 is what? Dependent on what? Resting membrane potential is dependent on what?
Sodium, mostly sodium.
Resting. What brings the membrane to rest? Potassium. Right? Potassium is the one which brings the membrane to rest. And if that resting means more negative. So how this potassium can change that depends on we'll talk. That's what we'll talk here. So let's look at hyperosmolality, means we have higher potassium concentration. So there are two different things here. So here is the muscle cells and here is the kidney cells in the collecting duct. Okay. So when potassium concentration in the extracellular fluid goes up, all you are doing is dragging the potassium away from the extracellular fluid. And there are different mechanisms of doing this. How do you drag the potassium away? By first is the hormonal level, the aldosterone. So when the potassium goes up through angiotensin II, also this aldosterone pathway is stimulated. And once the aldosterone is released, it will, as we talked about, the sodium-potassium pump. So the sodium goes, 3 sodium goes and 2 potassium comes in. So this potassium is going to be brought into the cell, right? And because 2 potassium is coming in, 3 sodium will leave. So you're dragging the potassium into the cell. So that's what, through this pathway in the collecting duct cells, that's what they will do, and they will correct for potassium. As well as, because potassium is in your blood and serum, so there is another pathway, insulin. So the insulin will also acts on this channel, but these are in the muscle cells. So right now, here we talked about the kidney, but in the muscle cells, through this beta adrenergic catechol release, this will also activate this channel, and through insulin, this channel gets activated to drag the potassium into the muscle cell, so that you can bring it back to homeostasis. So by these two different mechanisms, that's what you are dragging the potassium. But when you are doing this, you're shifting your pH. That we'll talk about in a minute. But hold this thought, by dragging the potassium into the cells, you are also shifting the pH. So let's see how. So I know this slide is dense, but this is more for you to understand. What I'll talk about are these two pumps. So there are efflux pumps and influx pumps on the cell. So efflux pump is associated with the proton, the hydrogen ion. So hydrogen is always moving in this direction from inside of the cell towards your serum. Whereas the potassium pump, here, sodium, potassium, we all know that the potassium is always brought into, so it's dragged into the cell, okay? But they all are working together. These two pumps are working together. How fast and how slow they work depends on how much they need to correct. How much, so since we are talking about serum, pH, so say suppose the pH is high, means protons are low, right? So we are talking about serum. So let's see here. So here the serum pH is high. So protons, you need to bring in more proton, right? Because you need to correct. You need to correct. So this pump will work more to bring more proton out of the cell, so that it can correct that pH. The pH is high, you need to reduce the pH. So how do you reduce the pH? By bringing more proton. So this pump will start working, it will bring more proton. So as you're bringing more proton, this works in the same, like this pump goes together, so it has to move more potassium in. So if this works, keep on working, what do you think will happen? The more the pH is being corrected, the more potassium is going in, can lead to what? Hypo, right? So it will cause a hypokalemia because you're trying to correct for pH. And the more pH is shifted, the more potassium is going to get dragged in. So you are low in potassium, exactly. However, opposite will happen. So proton will never go in. It will always go in this direction. So it's always a efflux pump. Okay, so it cannot take in proton. So it cannot correct it that way. So this way, like here, the opposite will happen. So where is proton higher? Outside. Because serum pH is low here, right? So protons are high outside. So you need to so how do you prevent bringing more? So by slowing this pump, so that the more protons are not coming out. So you slow down the pump. When you're slowing down, the previous one though, you were making the pump work faster. Here, the pump is not working. It's slowed down because the pH, it wants to reduce the proton. So how do you reduce the proton? By not dumping in proton. So it slows down. As it slows down, this pump will also slow down, right? So what do you build there now? If it slows down, the potassium is going to be more in the serum, right? Because both the pumps are slowing down. So you're building your potassium in your serum, and that may cause what? Hyperkalemia. So all these two slides is what is saying. How are you going to, what we are addressing here is correcting the pH. By correcting the pH, we may end up in another problem. And this depends on how bad it is, right? It may not be as bad, so it may not have hypokalemia. Its extreme cases may cause that. So now we talked about, so now we're talking, reverse can also happen, right? We are now correcting for potassium in this case. So like say suppose serum potassium is high in this first case, which is hyperkalemia. So here the more potassium is here. So how do you correct it? By shifting into, right? So that means this pump is working really hard, is really working fast. So how will that impact, will this pump work faster? In return to compensate, right? So then what are you going to create here? The pH problem, right? So you have corrected for potassium, but maybe you'll create a problem for the pH. So it's a balance of both. You have to correct it based on your pathophysiology, yes.
Are we correcting the pH in ICF or ECF?
Hmm?
Are we correcting the pH in the ICF or ECF?
You're always correcting in the extracellular space. You're always correcting your serum. You cannot, inside of the cell is hard to reach. So you're always correcting extracellular space. The serum is the extracellular space. Yeah.
In this S-chain, sodium is not involved.
Say that again?
When this S-chain of potassium and the hydrogen ions take place, sodium is not involved.
Sodium is involved because you're saying like you are correcting for potassium. Potassium is 2, potassium goes in, 3 sodium comes out.
So what I don't understand is if potassium and sodium exchange and they are both the same kind of why does it alter pH?
How does it?
I'm saying sodium is 1 plus, potassium is 2, it's also 1 plus. They are both alkaline.
Yeah, but there is buildup of. You have to think about our blood is already acidic, not because of sodium or potassium. Maybe there are some other reasons, like your respiratory. I mean, we haven't learned about that topic, but your lungs are involved in acidic and the alkalinity of the blood, right? When you are breathing in and out, or also your pH can drop because of imbalance of bicarbonate, that when you are metabolizing your during the day.
Yeah, we'll talk more about acid base on Friday.
Right.
But my question is, now that potassium is exchanged for sodium, are we supposed to understand this as if sodium is not existent? Because every time we put potassium goes in, I'm expecting sodium to come back to that space.
I don't think there is sodium is not correcting your pH. Sodium is changing the osmolarity of the solution, right? So sodium is not, like when you measure your pH is the hydrogen ion concentration or the hydroxyl ion concentration.
Yeah.
So sodium is not going to correct your pH. Sodium ions, like when you measure the pH of a solution, the definition of how you measure is how much protons or the hydroxyl ions are there. So sodium hydroxide, you correct the pH by, like say acidic, then you neutralize it with sodium hydroxide, right? Because you're adding hydroxyl. But here there's no hydroxyl here. It's only sodium is coming out.
Okay.
Does it make sense?
Okay.
Because here we are talking about the hydrogen ion concentration. Yeah. So that hydrogen ion concentration is changing or rising or falling. That's shifting the pH.
Okay.
So the other pump is not helping. Is sodium is not in a sodium hydroxide
Okay.
format. Okay. Good question. So we now have created, so we corrected for hyperkalemia, but we created the pH imbalance. So now the pH is going down in this case. Okay. So I'm not going to review the opposite, what happens, but it's the same opposite can happen where the pump is going to slow down to build the potassium. If this pump slows down, this pump slows down as well. So now we have the opposite problem. Okay, so the pH. Yeah. Increase in pH will happen. So I think these two, hyperkalemia and hypokalemia, you'll learn more in your clinical lecture. So I'm going to skip that. But there are therapies. So what drugs do you use? Let me take a quick break. I need a water.
I definitely cover that.
You cover that?
I'll cover that tomorrow.
Okay. How are we doing time? Yeah, so we covered this. So let's see. I think I already talked about the therapy, like how to stabilize your membrane. Basically, you're stabilizing the membrane by calcium gluconate and calcium chloride. So then it increases the threshold potential. Means like this threshold, the gap increases so that you don't produce these blips of action potential. So it stabilizes the membrane, heart membrane. So it prevents the cardiac arrhythmia associated with hyperkalemia because higher potassium can do that. So again, I already talked about the redistribution. So these are the drugs you're going to use it: insulin, albuterol, and bicarbonate. So this is more of correcting the acidosis of the pH blood. It's more of indirect potassium movement, but you already saw these two mechanisms today. I already mentioned here insulin, and this albuterol will act on the beta adrenergic, which is an agonist here. So we also need to eliminate potassium from the body, right? So these are the drug that you will learn. The way it happens is you provide a resin. And these resins will bind your potassium, and then the potassium will be excreted out. So that's how you you remove the potassium from your serum. So last but not the least, we have a scenario here, the patient with a severe hypokalemia, and you are giving the patient potassium, but the levels are not changing. Why? Magnesium, exactly. So this proton pump, this sodium potassium pump will work only when there is magnesium is there, because magnesium acts as a switch. It's a cofactor for this pump to open and close. And because magnesium binds to ATP. And if the magnesium is not available, then this pump will not open. Okay, so and these are there in the DCT region of the nephron. So as I already said, it's essential. So if there is no magnesium, pump cannot use ATP, no potassium, and sodium transfer will happen. So that's all I have for the science. Yeah. So also it's involved in hypocalcemia. You will learn that later. If there's no magnesium, that will impact that. Oh. Okay, thank you. Any questions? There are some practice questions for you, and you can do that at your convenience. Thank you for your attention.
Thank you.
Thank you, Dr. Joshi.
It's a big,
Dr. Joshi,
yeah.
does the body have a mechanism of eliminating sodium from the body?
Say that again?
Is there a mechanism of eliminating sodium ions from the body? Because it seems as if 99% is taken back in the kidney.
Yeah.
So only 1% can go.
So the only way to remove sodium is by diuretics, right?
Only by diuretics.
Yeah. So there is no specific other that I'm aware of.
Thank you.
Mhm.
Thank you.
Right. We're going to move on to volume assessment right now. Make sure you familiarize yourself with the learning objectives. So remember, goals of fluid therapy, whatever you intake, whatever you drink should come out, right? Those should remain equal in general. So in general, you're intaking about 1,800 cc's or mils of fluid every day in water or other fluid. As far as food, it's up to 1,000 mils of fluid in the food. Then oxidative processes up close to 400. Output, you see here, urine output, 1,800 or so. Stool, about 100 mils in the stool. Fluid is lost in the stool. Skin, insensible losses up to 500 in normal states, right? In abnormal states, you can certainly lose a lot more fluid through your skin. And then lungs, you lose a fair amount of fluid just by respiration, exhaling. So almost a liter of fluid in your lung. So your body wants to maintain homeostasis with fluid as well as electrolytes, which we'll talk about soon. So these should remain equal. When they don't remain equal, then you have issues, right? Either hypovolemia or hypervolemia. So just some definitions. Water is really just the amount of water in the body itself. Volume is the amount of water and effective solute in the body. And the solute in the extracellular fluid is mostly sodium, right? That's the main determination of osmolality. So sodium really regulates the amount of volume in the extracellular fluid. So a patient's volume status, again, can be described as hypovolemic, meaning the volume status is low, euvolemic, normal volume status, or hypervolemic. We saw or learned a lot about hypervolemic in congestive heart failure, right? Where those patients tend to have quite a bit of volume on board. And there's a lot of other disease states that will cause hypervolemic as well. So this is kind of a review with your intracellular fluid on the right-hand side of the graph and the cell membrane right there, and then your extracellular fluid. Remember, we can only clinically assess the extracellular fluid, right? We can't go inside the cell and determine how much volume is there. So we can certainly assess the extracellular fluid, though. The majority of that is going to be the intravascular volume as far as assessment. Interstitial volume is very difficult to assess. So what we are clinically assessing is the intravascular volume or the plasma volume. So a person's volume status can be described in a couple ways. Their extracellular fluid volume status, the interstitial space, or their effective circulating volume. So that would be their intravascular space. So the amount of fluid in your vasculature, your arteries mainly, some of the venous as well. So these two volume statuses can be the same or different. So you can have a hypervolemic in the intravascular space and then hypervolemic in the interstitial space, or vice versa. When you develop a plan for treating these two volumes, effective circulatory volume is always treated first. Why is that? What's it?
because of the pressure,
What pressure?
blood pressure.
Blood pressure, exactly. So the effective circular volume is important for the blood pressure, and more important because of the perfusion pressure of your main organs, such as your brain, heart, kidneys, etc. Right? So this ECV takes priority in all other cases as far as volume status. So adequate tissue perfusion is just a sufficient delivery of oxygenated blood to the tissues or organs. Certainly when you have decreased intravascular volume, you can have decreased perfusion to those vital organs, right? So we need to treat that. So it's certainly essential for maintaining cellular function and preventing organ damage. Regulation of volume involves the regulation of plasma volume, the intravascular volume, and blood pressure in order to maintain the adequate tissue perfusion. So this is a review, but the volume regulation occurs in 3 steps. You have baroreceptors, osmoreceptors, et cetera. When they sense a decrease in blood pressure, there's a decrease in ECV as well, right? Because those are related. So once that happens, then you'll have a signaling pathway with the renin, angiotensin II system, and aldosterone and ADH that will act on your kidneys to reabsorb water. That should increase your plasma volume and then directly increase your blood pressure over time. So it's a feedback loop, basically. So your effective circulating volume is influenced certainly both by your plasma volume and your blood pressure. Plasma volume and blood pressure can either move in the same direction or opposite. And then a decrease ECV describes tissue hypoperfusion, which is most easily recognized by a decrease in blood pressure. Remember, blood pressure is cardiac output times peripheral vascular resistance. So a decreased ECV can be seen with both ECF, so extracellular fluid, hypovolemia, and hypervolemia, as depicted here on the little graphics here. So you can have a hypovolemic state, low blood volume, and a low effective circulated volume. Then you can have a patient who's hypervolemic and a low effective circulating volume. What kind of disease states will fall into either one of those categories? So hypervolemic with the low effective circulating volume is what type of disease state?
Patient who is dehydrated?
Dehydrated? No. That would be on the left-hand side. So if you have hypervolemia and a low effective circulating volume.
For example, like edema, and you heart failure with the
So heart failure for sure. When you get to hepatic liver disease can give you that. Anything that's going to increase the volume on board. But remember, the volume goes everywhere, right? It goes in interstitial space, it goes intracellular. So you can have an increased volume on board, but still have a low volume in the intravascular space. So that's the most important thing that I want to point out. So those patients would be congestive heart failure patients, liver disease patients, anything that's going to cause an increase in volume. This would be more in line with dehydration, right?
Yeah.
You have a low volume in general across the board and low in the intravascular space.
Dehydration is the other one. Which one?
What's another one?
Dehydration is
There's-
to the left.
There's many. There's like blood loss, so hemorrhagic shock, any type of like distributive shock, anaphylactic shock, in general will give you hypovolemia and decrease intravascular volume.
Dehydration is hypo, not hyper. It's not like
Hypo. Dehydration. Hypovolemia. So, and think about it. When you're dehydrated, what happens? What are some of the symptoms when you're dehydrated?
I thought you said hyper. That's what.
No, we thought you said hyper for
Yeah.
the.
I'd say
Hypo.
Yeah, so that's
So when you're dehydrated, what kind of symptoms do you have?
Thirsty.
Thirsty, right? You definitely want to drink water. You may have dry mucous membranes, right? You may have decreased urine output over time if you're severely dehydrated. You can't have orthostatic hypotension. What is that?
You get up.
I get it up.
You get up suddenly and you collapse.
Dizziness.
Easy, fall down.
So it's a change in blood pressure or a change in heart rate when you get up, right? So when you're sitting down, check your heart rate and vitals, blood pressure. They may be at a certain level. When the patient stands up, their heart rate's going to go up, their blood pressure is going to go down. Tachycardia, vomiting, diarrhea, etc. All signs of hypovolemia. For hypervolemia, certainly increased weight, right? We saw that again with congestive heart failure. Peripheral edema, ascites in some disease states like liver disease, pulmonary edema, you can see that, etc. So be aware of these signs and symptoms of hypovolemia and hypervolemia. So normal effective circulating volume really is adequate blood pressure to perfuse your vital organs. I mentioned that. So low, you can have relative hypotension, orthostatic hypotension, and orthostatic tachycardia. So in your assessment of the patient, what you're going to want is a good history and physical exam. History is important, right? Like if the patient has had diarrhea or a fair amount of vomiting over the past 3 days, that would go in hand with hypovolemia. Certainly vital signs and orthostasis, like we just talked about, those are very important to help you assess the patient's volume status. Urine output, like we talked about yesterday, right? A trend in urine output, urinary frequency, etc. And then any laboratory tests to help you assess volume status. That should help put the whole picture together. And just like we talked about yesterday, you're not using just one of these things. It's a whole package that's going to drive your assessment of the patient. So goals of therapy for volume is certainly to restore effective circulating volume. That's the number one goal. If you do that, you should be able to maintain tissue perfusion and perfusion to your vital organs, specifically the brain and heart. You want to prevent organ dysfunction. So one of the organs that is going to be impacted first is which organ? If you have a decrease in effective circulating volume, which organ is going to be impacted first? I heard brain, I heard heart. What's another organ? Kidney. Kidney is going to be affected, and your brain is going to be affected. Those two are going to be affected the most. Certainly in the elderly, they're more predisposed to mental status changes if you have decreased blood flow to the brain. But your kidney is not as important as like your heart or your brain. So your body's going to shunt blood from the kidney and try to perfuse your brain if it needs to. So your kidneys are somewhat expendable, unfortunately. So you want to certainly prevent any organ dysfunction, but one of the first signs would be either CNS changes or changes in renal function. And then correct the underlying cause of the fluid imbalance, right? So you want to identify the cause and then treat that to hopefully treat the volume disorder. So how do we do this? We could do this in two different patients. One, would be resuscitative fluids. So if they have decreased intravascular volume, we're going to need fluids to resuscitate, to increase that intravascular volume to hopefully perfuse our vital organs. If they have normal blood pressure and normal perfusion, then we're going to just use maintenance fluids, okay? We're just going to make sure that they have adequate maintenance fluids throughout the day to help them maintaining their tissue perfusion. So the first one, again, if your patient is hypotensive or showing signs of decreased organ perfusion, you want to pick an agent that's going to restore the plasma volume. So what kind of agents that you learned about, hopefully in the last 24 hours, which would stay in the intravascular space?
Normal saline or lactated ringers.
So I heard normal saline or lactated ringers. And why do those solutions stay in the intravascular space? Speak up. I'm sorry.
They can't cross the cell membrane.
What's in those solutions?
The electrolytes,
Specifically, which ones?
sodium.
Sodium's so important, right, for those solutions. So sodium is going to help bring water into the intravascular space. Some is going to get across and go in the interstitial space, but 25, 30% will stay in the intravascular space. Whereas if I gave just regular tap water like this, where is that going to go? Everywhere. So if you give this in your vein or something like D5W, which is similar, it's going to go everywhere. It's going to go in your intravascular space, but it's going to also get across the cell membrane and go in the interstitial space. So it's not going to stay intravascularly. So you need something like that has a fair amount of sodium, right? And that's what normal saline is. 0.9% normal saline has like 154 milliequivalents of sodium. Lactated ringers has about 140. So that sodium is going to help stay and replete the intravascular space. So those are called crystalloids, right? And that's what we generally use for resuscitative fluids. We would typically bolus those crystalloids. So maybe 500, a liter of crystalloid solution over a short period of time, so over 15 minutes. That's called a bolus. So what you're doing is putting it through an IV catheter in the patient's vein and rapidly infusing this solution, this crystalloid solution, to restore the intravascular volume. Does that make sense? So what you're going to do is give a bolus and then assess or reassess the patient mainly for perfusion of your vital organs and blood pressure, right? That's your goal endpoint for resuscitation. And then if they need more, you give more. So it's a constant administer the drug or solution, reassess the patient, and then stop when it's restored. So if it's maintenance, remember they're normotensive. They have a normal blood pressure, right? They have normal intravascular volume. You just want to maintain their perfusion. So what you're going to do is something like this. I usually use 20 to 40 mils per kilo per day, but other equations would be 1.5 liters plus 20 mils per kilo for every kilogram over 20 kilograms. So you can use either one. They're going to give you roughly the same amount of fluid. They're off by a factor, but I just find it easier to remember 20 to 40 mils per kilo per day. Any questions on fluid repletion? So this one, you're going to use crystalloid. This one, you don't really have to use crystalloid. You can use a combination of D5W and crystalloid, but you're probably not going to use 0.9% normal saline on maintenance fluids, generally. So remember, volume regulation is super important to maintain body homeostasis and to, make sure our organs are perfused. Effective circulating volume equals plasma volume plus blood pressure. Plasma volume and blood pressure are maintained by all those factors that Dr. Joshi mentioned. So don't forget all those feedback systems and hormones. Remember, a patient may have the same or different volume assessments in their extracellular fluid and their effective circulating volume.
Prof, if I have a patient who is obese, I'm just wondering, how do we actually establish what is the total volume of water, whether the patient is hypervolumic or hyper?
If you have a patient what?
Who is obese?
Hmm?
The patient is obese.
Obese.
Obese, yeah.
You're still establishing their volume status, right? So you can get a blood pressure, you can get orthostasis, you can get heart rate. You can do all those assessments on the intravascular volume to get an estimate of the intravascular volume. History and physical is very important, right? That history, don't forget the history of what brought the patient in. And you add all that together for your assessment of the volume status. So here we have a 48-year-old female who weighs 65 kilos. She is NPO. What's NPO? Nothing by mouth, nothing per mouth while awaiting surgery. So she's here for surgery and is written for continuous intravenous fluids. How much should she receive? So is this lady, which category is this lady going to be? Is she going to be in a resuscitative person or a non-resuscitative? Probably not, right? She's here for a surgery. She's stable. We don't have that data, but we're going to assume she's stable. So you can use either one of those calculations that I showed you on the other slide to calculate her maintenance fluid, basically. That's what we're going to do. So if you chose the longer one, 1.5 liters plus 20 mils per kilo for every kilo over 20, you would get this. So 20 mils times 45 kilos, which is 45 is over 20 is 900 mils. So you have 1.5 liters plus 900 mils is about 2.5 liters over 24 hours. That would be her maintenance fluid. And that volume is actually pretty close to what I gave you initially, right? On like the second slide when we talked about intake versus output. So that is a fairly normal adult input as far as fluid. So what you would do is probably divide that over 24 hours, and then you can administer it at 100 mils per hour. So if you chose the other route, which I would, because it's simpler, so 20 to 40, so I just put 30 in between, 30 mils per kilo times 65 kilos gives you 2 liters, or just round up to 2 liters. Very similar, right? So 2 liters over 24 hours divided by 24 hours, and that's 83 mils per hour. So 2 calculations that you can use, and they're fairly equal. So I would say anywhere from 83 to 100 mils per kilo per hour would be totally fine for this lady. So volume assessment as far as our role, pharmacist's role, certainly we're going to review the patient history and get a complete history to help you assess that patient, interpret the physical exam findings that you may have from the other providers, look at the patient's blood pressure and heart rate and all the vitals, evaluate the laboratory data that can help you assess volume status. Identify medications that may contribute to volume depletion. We named one What's a medication that we use that gets rid of fluid?
And right,
Diuretics, right? So certainly there's a whole bunch of others, but that could be an important point that you identify. Recommend the appropriate fluids, so whether or not the patient needs a crystalloid or a non-crystalloid solution based on their volume status and what's going on. And then certainly to monitor therapy outcomes, right? Those are all important things that we can do as pharmacists. Any questions on fluid assessment? Okay, let's take like a 5-minute break, please. And then we'll talk about sodium.
Ah, ya entendí. Correcto, mira. Por eso no te podemos parecido al lento. Es que como que me tardo en captar. ¿Seré cómoda por eso? Siento que tanto que me nadie sabe lo que tiene hasta que lo tiene. Honestamente. So, Dr. Gonzalez, when the patient is nothing by mouth, we're gonna use the maintenance IV fluids, right? Because it's unable to tolerate whatever the week's patient.
Assuming your assessment does not identify like hypovolemia.
Okay.
Yes. So if their blood pressure is fine and everything that you're assessing and gathering the patient indicates that they're perfusing their organs okay, and you're not worried about that, then you can just do maintenance fluids.
Okay.
And it really depends like how long the patient is NPO for, right? If they're only NPO for like 6 hours, you can certainly go 6 hours without drinking anything. So it'd be more like prolonged NPO.
Okay. Hacho, el café estaba, era donde estábamos a recibir. Ese, lo hicieron, lo del Whitehouse. Una pesta medio rico. No, yo no, porque a veces estaba allá y a veces.
¿Fuiste tú por Carla?
Fue Carla y me.
La condena, no puedes decir. Sí, hombre,
A mí no me daba la pena.
¿de qué raro que le
Alexi le dio primero y después también me manché bastante. Sí, yo creo que era un acento.
no quiere apesta.
A mí no me da, pero quizás a Paul por lo que te da. A mí no me da. Huele raro, pero no es como café. Como un moca bombado tiene el amarillo.
Los tipos se han ocupado desde que empezaron las clases.
Mira,
Mándame.
ajá, espérate, dame a ver si
Yo lo tengo, pero
no debería haber pensado.
Mándame a mí.
No, espérate que no lo consigo, pero no. Envíamelo.
Ya está pendiente, no me estés mandando los días.
Después mira cómo pone los pies mandando, no voy a ver.
solo quiero decir algo.
Eso que eso tiene que ser bien incómodo, eso es como sentarse en el avión
Y
familiar.
yo soy chiquita y me siento incómoda, imagínate.
Oye, en esta salón no hay nadie hoy. Sí, pero que está como vacío.
Los primeros 5 minutos se
All right, I think I'm going to go ahead and get started on sodium. What we don't finish today, I have some cases at the end. I'm going to do them tomorrow at the beginning of tomorrow's lecture. But we should be able to finish most of this. So as far as sodium disorders and general assessment, I think this is a good pathway to kind of walk through determination of sodium disorders. First of all, you want to look at the serum sodium, right? That's the sodium in the extracellular fluid, and determine whether it's hyponatremic or hypernatremic. So you guys have to definitely know the normal values of sodium. So hyponatremia would be a sodium level less than 135, and hypernatremia would be a sodium level greater than 145. So first you start there. Once you identify either disorder, then you're going to assess for symptoms, and you have to know the common symptoms for the sodium disorders. So what are they? What organ is affected for sodium? The brain. So think of the brain, okay? Whenever you identify a sodium disorder, always think of the brain and symptoms that are related to the brain. Severe symptoms would be like, things like seizures and coma and things like that. And that's with the very high derangements of sodium levels. But always think of the brain with sodium, okay? You want to assess for the rate of development of the disorder. So did the sodium go from 140 to 120 over months? If it did, then it may not be as important to treat the patient back to 140 immediately. But did the sodium go from 140 to 120 within several hours? Then you want to treat the patient more rapidly. So use that as a rule of thumb on how aggressive you're changing the sodium level, whether it's hypernatremia or hyponatremia. So the time period, if you can identify from normal to whatever the patient presents with, you use that as a rough guide. I would say if it's acute, that would be defined as a sodium change of less than 48 hours, so less than 2 days. If it's more chronic, either hypernatremia or hyponatremia, it'd be greater than 2 days. Okay, so that's a good break point, and you should know these break points here. But that rate of change is very important when you decide whether or not you're going to treat the patient aggressively or not. You want to assess the effective circulating volume. So remember, these patients can present as hypovolemia, euvolemic, or hypervolemic. That's why we spent a fair amount of time on those three things. So certainly assess that, assess the patient's blood pressure, and then always try to determine the underlying cause. So whether we talk about sodium, potassium, calcium, even acid-base disorders, always try to identify the underlying cause, because you really want to treat the underlying cause of whatever disorder this patient may be having. Treat that along with the acute symptoms if they have those acute symptoms. So again, I think this is a nice pathway or step-by-step approach whenever you're working up a patient with sodium disorders. So again, acute symptoms would be onset of less than 48 hours. Certainly you can see seizures, like I mentioned, coma, respiratory arrest, or maybe even herniation of the brainstem. Chronic symptoms, which are lasting greater than 48 hours, those tend to be more mild because it is a gradual onset of the disorder. So you may have some, slight mental status changes, inattentiveness, things like that. They can be agitated, irritable. You may have some ambulatory issues, problem walking, stability issues, posture issues. Those can be seen. Some more moderate to severe would be lethargy, so just, tiredness, things like that. Nausea, headache would be one, and restlessness. So those are more mild to moderate symptoms. And again, that impacts how you treat the patient. So if you identify seizures in a patient, you're going to treat them a lot different than a lethargic patient, right? You're going to want to change their sodium back to normal, closer to normal, a lot quicker in this category than this category. So your treatment's going to be more aggressive. Your change in sodium is going to be more aggressive. So other principles, I mentioned treating the underlying cause. So you should be able to identify the underlying cause. For us, as pharmacists, there's a lot of drugs that can cause hyponatremia. So we want to identify if the patient is on any of those medications or drugs. That's why a good medical history is very important. You want to balance the risk of hyponatremia versus the complications of treating the patient too rapidly. The biggest complication for hyponatremia would be osmotic demyelination, and that would be a too rapid correction of the sodium level. So in a normal situation, when the body senses a hypotonic state, you'll have water gain in the brain. It'll cause cerebral edema. Why does that occur? So if your patient presents with hyponatremia, very rapidly you'll gain water inside the brain. Why is that? So remember about the osmolality and tonicity of the blood. So if it's hyponatremic, where's your osmolality? Is it normal? Is it high?
Low.
Low. It's low, right? And water goes from what to what? A low concentration to a low concentration, or a low concentration to what? High concentration, right? So in your brain, because of your blood-brain barrier, you're still going to have a high osmolality in the brain because of the blood-brain barrier. It's not, it doesn't equilibrate as fast as like your interstitial space. So therefore, the fluid is going to go from the low concentration into the high concentration. So go from the interstitial neurovascular space into the brain. That's going to cause cerebral edema. Your body doesn't like that, right? Your brain doesn't like to have too much edema on board. So it's going to rapidly have adaptation. You'll have a loss of sodium and potassium and chloride out to prevent that cerebral edema. So it's going to try to adapt over time. So you have a loss of osmolytes in your brain once it adapts to that hyponatremia, okay? So when you have a loss of osmolytes, sodium, potassium, etc., in your brain, and then you correct the hyponatremia with, how do you correct hyponatremia? Sodium, right? In the severe cases, you're using sodium, like hypertonic sodium. So that's going to go in the vein. And then you have a low osmolytes in the brain because of rapid adaptation. You start administering hypertonic saline, and then what's going to happen?
Water.
Yep. Water is going to leave the brain to the systemic circulation, and that's going to cause what's called osmotic demyelination. Okay? We want to prevent that. So to prevent that, what we're going to do is have goals in mind for changing the sodium level. And these are very important. So you want to increase the sodium about 4 to 6 milliequivalents per liter in 24 hours. Okay? So that means if the sodium level is 110 in the patient, you don't want to go higher than 116 in
106.
over 24 hours.
You said the water is important. Why the water can happen?
Which one?
The first one.
This one here? This one?
Yeah.
So that's because, remember, in hyponatremia, it's you have low salt in your blood, right? Because the patient has hyponatremia. They have low sodium, low solute, their osmolality are going to be low in the blood. In the brain, it's going to be normal because of the blood-brain barrier, and it doesn't equilibrate as fast. So acutely, if that happens, that could cause water going from your intravascular space, interstitial space into your brain. And that's going to cause cerebral edema. That is what causes seizures, coma, death. Okay? And this is all acute, if it happens acute. If it happens chronically, you're not going to have as much going on. But you're still going to have some cerebral edema. Does that help? It's because of that concentration gradient. So you have a low sodium level in your blood, in your interstitial space, but in their brain, it's going to be closer to normal. And so water is going to go from that low gradient to the high gradient. So if your patient comes in with a sodium level of 110, you don't want to go much higher than 116 in the first 24 hours, okay? That's to prevent badness, osmotic demyelination. Your max increase should be no more than 8 to 10 in any 24-hour period. So generally your goal is 4 to 6. And you're going to do it, and we'll get there, but you're going to do it based on symptoms. So you're going to monitor the patient and treat to the resolution of symptoms or until you hit this threshold here. So remember those goals. So hyponatremia, which is defined as sodium level less than 135, again, can be hypovolemic, euvolemic, or hypervolemic, right? And we're going to go through each one of these kind of categories. So just a quick slide on treatment. This is a nice summary slide for treatment. In hypovolemic, remember, when you're hypovolemic, you have decreased intravascular volume, not enough tissue perfusion. You want to improve that intravascular volume, right? So you want to fluid resuscitate those patients. So hypovolemic, you want to fluid resuscitate. That's why you want to identify their volume status up front, because that's going to guide your therapy. And then you're going to identify any causative meds that the patient is on, discontinue that. In euvolemic, so the volume status is normal, but the patient that comes in as hyponatremic, you're going to water restrict those patients. So you don't want to give them water. You don't want to administer water. Water restrict. Maybe you'll give salt tablets. That's not used that often anymore. Sometimes in neurology, they do that. You can use, Dr. Joshi mentioned the Baptams, Condobaptam, Tolzaptam, meclocycline. They can be considered in some of the cases. Again, identify and discontinue any causative meds. For hypervolemic, you want to do sodium and water restriction in that type of patient. Baptams may be considered. We have a slide on that. Loop diuretics can be used cautiously. And dialysis may be needed in spare cases if the patient has renal impairment. So this is just a nice summary slide. We're going to go into more detail, but this kind of puts it all together for you. So going back to hypovolemic hyponatremia, the cause is a volume loss. It's more of a volume loss. You're definitely going to lose sodium and water. Some causes would be diuretics, thiazide or loop diuretics, but more commonly thiazide diuretics. This is a common cause of chronic hyponatremia. So the patient could be on a thiazide diuretic for months to years, and then their sodium levels are going down. In that case, it's chronic. They're not going to have those acute symptoms, but they can present with a sodium level of 120 and still able to ambulate and converse and, no major symptoms. So you can definitely see that. Extrarenal causes would be diarrhea, excessive sweating, severe burns. Those would all be more acute causes, right? Certainly, probably you're not going to have chronic diarrhea, excessive sweating chronically, et cetera. So those will probably present more with acute symptoms. Clinical presentation, well, it depends on the patient's extracellular fluid and effective circulating volume, right, on how they present. If they have severe volume depletion intravascular, they're going to have signs and symptoms suggested of that, so decreased perfusion. And then they may have CNS changes if the sodium is severely low. So in this patient, hypovolemic, you're going to fill the tank. So you're going to fill the intravascular volume, and you're going to use saline products. Crystalloid products. Could be lactated ringers, something with sodium, like normal sodium level of 140 to 54. And then water. Normal saline, lactated ringers, plasma light, etc. Volume. Think of volume and replacing that intravascular volume. You may use hypertonic saline, but only in acute hyponatremia and severe. So what are symptoms of severe hyponatremia?
Seizures.
Seizures, coma. Okay? Those are probably the two main reasons to give hypertonic saline. If your patient is comatose, you want to correct that sodium fairly quick. If they're seizing, you want to correct that sodium fairly quick. If they don't have any of those, you're probably not going to use hypertonic saline. Euvolemic hyponatremia. One of the more common causes would be syndrome of an inappropriate antidiuretic hormone. So this would be too much antidiuretic hormone, and it's causing volume retention from the antidiuretic hormone. So they can present with persistent and inappropriate secretion of ADH in the setting of normal water ingestion. And this prevents the kidney from removing water, so that reabsorption of water. Their volume regulation is intact, therefore plasma volume is euvolemic, but they probably have an increase in intracellular volume. So their intervascular space is euvolemic, but inside the cells, there's too much volume. You can see neurologic symptoms, but mainly if the sodium level is fairly low. Treatment would be to remove that excess volume and then water restrict the patient. And then there's a nice little pathway here that guides you down one versus the other based on some urinary sodium levels. So if a urinary sodium is low, go down this route, it's more water restriction. If your urinary sodium is high, it's probably one of these things, hypothyroidism, SIADH, etc. Then you're going to do both water and sodium restriction. But for the purposes of your learning today, remember that it's mainly water restriction for euvolemic hyponatremia. And then hypervolemic hyponatremia, some of the causes would be congestive heart failure, cirrhosis, renal failure. Those are all patient populations that would have a ton of volume on board, right? Like that guy up there in the upper right-hand corner. So they're going to present with a ton of volume on board and a low sodium level. They may have decreased effective circulating volume. So it depends on their physical exam and blood pressure. Again, neurologic symptoms may be present if severe hyponatremia. But basically in this patient, you want to treat the underlying cause, right? So if it's congestive heart failure, you're going to treat that cause. So how do you treat that acutely? How do you treat congestive heart failure acutely? Diuretics. Diuretics, you want to get rid of volume, get rid of the fluid. They're going to come in, all congested, get rid of the fluid. It all ties together, guys. If their blood pressure is down, certainly you can give some saline and treat that. So that's your pathway there. Assess their volume status. If it's down, their blood pressure is down, resuscitate them, and then you're dealing with volume and fluid restriction later. But if their ECV is normal or high, then you would get rid of that volume. Yep.
When you euvolemic, when we excess water, why when euvolemic there's a balance?
So in euvolemic, there's more of an increase in intercellular volume generally because it's euvolemic, right? So what we're measuring in our assessment of volume status is really the intravascular volume. That's what we're calling euvolemic because that's what we can assess, right? We can't assess the intracellular volume. So in these patients, the volume is more intracellular, but intravascular is normal. So in euvolemic or hypervolemic, you can consider the Vaptins. Dr. Joshi mentioned these drugs, this class of drugs, and there's indications for SIADH, heart failure, and then softer indications for cirrhosis. They're not used that commonly, mainly because of the cost. These are all very costly drugs, and there's no good data on outcomes versus volume regulation and things like that. So really, you're going to use them in more refractory cases, mainly because of cost. This is already mentioned. Conivaptan is associated with hypokalemia, greater potential for orthostatic hypotension. The biggest thing is you may see rebound hyponatremia upon discontinuation. So you can certainly acutely treat the patient's hyponatremia, but once you stop that Vaptan, there could be a rebound in hyponatremia. So it can reverse and go back to normal. And mainly because look at the patients that you're using it in, like heart failure patients, cirrhosis patients. The drug is not going to correct that disease state, right? It's just not going to work that way. So they're not used that often. Maybe in refractory cases, you'll see it here or there. The other thing, as far as pharmacists, there's a lot of cytochrome P450 drug-drug interactions. So treatment of acute or severely symptomatic euvolemic hyponatremia, the priority is to prevent ongoing cerebral edema. So we talked about I showed you the slide with the brains and the cerebral edema there. You want to prevent that. So generally, what your goal is going to be is in the 120s. It's a soft goal, but you're not going to push it much higher than 120. You're certainly not going to normalize a patient's sodium level. And what you want to do is treat to the symptoms. So if they're seizing, you're going to treat until they stop seizing, or until you reach these thresholds like I mentioned. If they have a coma, you're going to treat until they're not comatose anymore. So it could take a while depending on the patient. But remember these goals. So increase 4 to 6 milliequivalents per liter in 24 hours and no more than 10 milliequivalents per liter in any 24-hour period. We already talked about the consequence of too rapid correction, the osmotic demyelination. So that would be the major concern with overtreatment. And what you're going to do is hypertonic saline. So what I want you guys to know here is that most hospitals will have an institutional process or protocol for hypertonic saline. You're going to see this at majority of hospitals. You can calculate a sodium deficit. The calculation is in your notes in the slides. You don't have to know that. What you need to know is a general dosing here. So if you're to treat someone with hypertonic saline, this is a more common regimen: 100 mil of 3% sodium chloride bolus over 10 minutes. Repeat up to a total of 3 doses over a period of 30 minutes. So that's generally what most people are going with nowadays. And then what you're doing is giving them 1 bolus, rechecking the sodium, looking at symptoms. If they are still symptomatic, give them another bolus and doing the same thing until they're asymptomatic or symptoms are less, or you reach those thresholds here, the goal of therapy. And you really don't want to go past this in 24 hours, okay? Once you go past 10, that's where the risk of osmotic demyelination goes up quite a bit. This is just the whole package put together. So it starts with a hyponatremic patient. You have to assess serum osmolality and assess volume status. Once you assess volume status, you go down a hypovolemic path, euvolemic path, or hypervolemic path. For hypovolemic, again, you want to assess intravascular volume status and the need for volume repletion. So you're going to give isotonic fluid there, sodium chloride. For euvolemic, it's mainly water restriction, unless you have SIADH, kidney failure, or things that will have a high sodium, urine sodium level. So remember, your sodium regulates your kidneys regulate the sodium. So if you're spilling sodium in the urine, you probably have something going on with your kidneys, right? Some type of defect, kidney disease, etc., or SIADH. So there you're going to do water and sodium restriction, and then in the hypervolemic, you'll do water and sodium restriction as well. So just a nice summary of the treatment there. And with that, I think we'll stop. We'll pick up hypernatremia tomorrow. I have a couple of cases on hyponatremia and hypernatremia that will kind of solidify how to assess your patient and go walk through a patient case. Then we're going to spend some time on potassium magnesium, and a little bit on phosphate and calcium. You're going to get phosphate and calcium with Dr. Hall in chronic kidney disease, so I'm not going to cover it to a great extent. So it's going to be mainly potassium tomorrow. Thank you. Have a good night.
Hoy, yo no me preocupo para el mundo, si me podrían ayudar.